Good afternoon for everyone, and welcome to our 2020 webinar series for Medical Middle East. Today's webinar's topic is about the management of wound infection and biofilm with Medical International Medical Director, Mr. Emilio Galia. So we welcome you, Mr. Emilio, as usual. And
thank you very much, Maher. We're going to talk a little bit about something that unfortunately we see many times, which is wound infection, and we'll discuss together as well biofilm, which is a very interesting topic, and try to recognize how we see biofilm in the wound and what needs to be done to both treat it and prevent it. Just a little reminder that microorganisms and bacteria have been around before us. They will probably be around after we leave. And one of the interesting things is how microorganisms mutate. And nowadays, if you go to Facebook or open the news, we know all about this because we've heard about it so many times. But what is happening now, the mutations, we're not talking about the pandemic, obviously, but inside the wound bed, how planktonic bacteria and planktonic microorganisms are evolving even inside our patients' wounds. What is the impact of infection? If you look at infection, the infection rates are still very high. More than half of chronic wounds will become infected at one point in time or other. The complications are great. If you look at diabetic patients, their risk of hospitalization, their risk of amputation is a lot greater once they get an infection. And we're not just talking for diabetic patients, especially thinking of obvious issues like osteomyelitis. We have to remember that these diabetic patients are much more prone to infection than other patients. And this to keep in mind about another discussion we will have today. Even talking about non-chronic wounds, things like surgical site infection, which is quite a huge burden and quite a huge problem as well. And the costs are enormous. The cost of healthcare, the cost for the patients, and we're not even talking about the health-related quality of life costs here. We're just talking about the money issues. So if we want to say in a nutshell, easily, what infection is, we're talking about a wound which is a breach in the skin integrity, which will allow those microorganisms to go in. And especially chronic wounds harbor this high amount of microorganisms. When we're talking about microorganisms, and I'm saying microorganisms, not bacteria here, you realized why in a few slides. It's not just the number, because many times we look at the log number, but even their virulence, how strong are they, and what is their ability to multiplicate and form colonies. Once they start multiplicating and forming these colonies, then we end up in an inflammatory stage where we can't go forward because the host protection, which is the neutrophils, macrophages, etc., are overwhelmed. They cannot control the problem inside the wound bed. And this is just an acronym to remind you about important things inside our wound when we have an infection. Infection is a clinical diagnosis and we have to treat it as such. If it's a diagnosis, we have to manage it according to the diagnosis. Microbiological samples should not be taken as a routine. Look at our policies and what do our policies say about taking microbiological samples. The usual suspects, Staphylococcus aureus, I know is very common and many people know about it, but even other like beta hemolytic streptococci. Remember that normal flora is normal. A wound is always contaminated. We should not treat all wounds as infected wounds because sometimes we do. we go ahead and clean and flush all our wounds. Should we be doing that? The antibiotic or the antimicrobial even prophylaxis, should it be done or should it not? And we'll have a small discussion about that. And remember that slough should be removed. And we're talking here about slough in chronic wounds, not slough in acute wounds. That's something. And we should always remove it before taking any samples. But also looking at how much our patient is prone to get a wound infection. And this starts us thinking about that issue about prophylaxis. One of the things I remember when I came in the beginning to the Middle East was, why are we using so much silver in our patients? And I quickly realized it's because of the environment of the wounds that we treat over here. Makes them more prone because of certain issues that we find in our patients, especially patients who are living in poorer conditions. We look at the high degree of problems there is for the local factors, but also looking at the patients themselves. What is their immunodeficiency? Are they immunodeficient? What is their nutrition, et cetera, et cetera? So this is important to make a good assessment in the beginning of our patients of how much prone they are for infection or not, to think about prophylaxis antimicrobials. Look at the comorbidities. Are these patients sick? And remember that usually chronic wounds happen in older generations. I'm not saying that they only happen in older people, but mostly they do. And the older we get, the more problems we have. So the more comorbidities we have, the more probable issues that we might have. Look at what the medications are for these patients. What are they taking that could make them more prone for infection? What are the psychosocial factors that I already hinted about? What about their hygiene? What about where they are living? What about their unhealthy lifestyle choices? Thinking about smoking and thinking about poor nutrition. When we're talking about nutrition, it doesn't mean that the patients are only emaciated. Even obese patients are more at risk. And characteristics of the wound care related hygiene. How are these wounds being taken care of? And this is why sometimes people come to us in our clinics with very infected wounds, because they have been trying to treat it in the community with less than proper standards of wounding. And where does the contamination come from? The environment around the wound. And when we're talking about the environment, we're thinking about even poor techniques. We're thinking about iatrogenic factors. We're talking about the surrounding skin. The normal skin flora is normal for the skin, but it is not normal for the wound bed. And other areas like the mucous membrane, especially thinking about, even if we're talking about surgical site infection, thinking about gastrointestinal operations, how much prone these are for infection. So basically, in a nutshell, it's breaking the balance of the wound bed. A wound bed should have a harmonious balance. That wound healing environment. However, if there is bacterial infection, microorganisms in the body, in fact, evoking this inflammatory response, then we are in trouble. Excuse me. And also thinking about exudate, because usually when we talk about exudate, we always think about exudate as being bad. And this can be a case. However, normal exudate is normal and it's important. It includes the nutrients and create that moist wound environment. But looking at that dressing before we throw it away, examining the dressing, taking note of what type of exudate is there. What is the viscosity? How thick the exudate is? Does it actually have a color? Because different colors give us different ideas of what is going wrong, as you see here on this slide. And even attribution of the odor, and I'm sure that all of you can recognize a pseudomonas infection from 100 miles away. So the exudate is I always call the exudate the storyteller of the wound. Tells us exactly what is happening there. Now, one of the questions that always arises is wound swab, wound cultures, microbiology. Unfortunately, there are some physicians that order microbiology as a routine. And if we look at, and this is taken, if you see the reference there, this is taken from the World Union document. They do suggest that we don't take them as routine. We only should take them when necessary. And these are some of the suggestions that they give. Acute wounds, which are now showing infection. Chronic wounds, but only when they are showing signs of spreading infection. If we have infected wounds that have not responded to our management, and obviously in accordance to our protocols and procedures. But even if we want to recognize a certain species there, and these are discussions, and there's a lot of articles about it. If we're using a broad spectrum antimicrobial, why do we need to know what type of microorganism there? And if we are using an antimicrobial which is working, then it's not an issue. So think about why and when we should take these microbiological samples. Now, if we have to take a sample, how do we do it? The 10-point method, the zigzag method, has been with us for time immemorial. Since I was a student nurse, I remember taking these types of samples. But is it very reliable? If you look at evidence, it definitely isn't. The gold standard is a tissue biopsy because it tells us exactly what is happening in the tissue. We don't care about what is happening on the surface because the surface, we will flush it away in any case. However, this is quite costly and we can't do it in every wound. So if you look at the literature, if we do need to take a microbiological sample, the best way how to do it is the Levine technique. And it has been shown in systematic reviews that it is the most effective because it can be done easily, can be done by anybody, and is not as costly as biopsies. What is very important to remember is that you need to clean the wound first before you take the sample. You don't want just to take that surface. Make sure that you try to go as deep as possible. And don't keep the swabs refrigerated. Send them as early as possible to the lab so that they are in a good condition as much as possible. And if you take a swab from the pus, exudate, etc., you have to tell the lab that this is a pus swab, not a wound swab. Because if we're taking a pus swab, first of all, it doesn't make sense because we're going to flush that pus away in any case. So signs and symptoms of infection, what is happening here? And this is a very good mnemonic from the guys from the IIWCC, Gary Sibold and his colleagues, where they talk about how we can identify superficial infection to deep infection. So when they're talking about superficial infection, they're talking about NERDs. So we have these wounds which are not healing. There is an increase in exudate. The tissue is very friable, so when you touch it, it bleeds quite easily. There is a little bit of debris, and there can be a little bit of smell around the wound as well. If we're talking about deep infection, they talk about stonings. So increase in the size, the wound is becoming more big as it progresses. The peri-wound temperature is increasing as well, which starts showing to us that apart from the wound infection and locally, there is spreading infection. Especially in diabetics, does it probe the bone? Does it probe to os? New satellite breakdowns, we start seeing other wounds appearing beside the original wound, which shows again spreading infection. Increase in exudate and erythema, and a very much more increase in smell than we have when we have only local infection. And the wound infection continuum, and I'm sure you've seen this, but we'll go in deeper into what are these definitions. Two things I want to make sure that I highlight here, that When we have contamination and colonization, the international guidelines tells us that we don't need antimicrobials. We're not talking about antibiotics here, the topical antimicrobials. However, again, the discussion is the patient at risk of infection? And will the patient benefit if we use the topical antimicrobials? So we have to weigh each patient in a different manner than we weigh all. We can't say everything is the same for everybody. If it's a patient who is immunocompromised, diabetic, etc., we probably would need to use these prophylactic antimicrobials. The other discussion is also the biofilm, where the guidelines suggest that we only have biofilm if we have local infection. But there's a discussion now that chronic wounds probably have biofilms almost from the beginning. So does it make sense, before using dressings to enhance wound healing in chronic wounds, does it make sense to use that dressing to make sure that we eradicate that biofilm before it gets out of hand? So what are the changes that happened lately? This is in the past 3 or 4 years. I'm sure most of you remember the statement critical colonization. That has now been removed. It was quite confusing. So they wanted to make sure that when we are talking about the stages of infection, we have clear guidelines about it. I mentioned this before, microbes or microorganisms now should replace bacteria. We shouldn't just be talking about bacteria, because there can be other organisms, for example, fungi. When we're talking about contamination, we are talking about the microbes, which are still planktonic. They are easily removed. They don't have cause a problem. And this is the normal status of every wound. However, we have to be sure that we don't involve cross-contamination and exposure to the environment. Colonization is now when these microbes start to proliferate, they start multiplicating. However, the wound healing is still going on. There is no impedance or delay. They are not at a critical level where they start showing us problems. However, we might start seeing a little bit of signs and symptoms, like a slight increase of exudate. Local infection is what it is saying. The infection is localized only to the wound bed. However, now these microbes have started to move deeper into tissue, and because they are deeper into tissue, now they start invoking a response from the host. So what are these signs? So the open signs, the covert signs, these are the usual signs that sometimes we forget. The covert are the subtle signs that we sometimes don't realize that they are there. Some things like you see in the picture at the bottom on the left-hand side, that little bit of bridging over there. Are there any pockets happening? And one of the things that we talk a lot about is hypergranulation. And many times we don't even realize that this hypergranulation is a sign of infection. That is friable tissue. If you touch it even with a little piece of gauze, you see little bubbles of blood coming out. It is bulbous. It looks like little bulbs over there. So that is dangerous. We have to take care of the infection. Sometimes just by removing the microorganism by means of antimicrobials and antibiotics, that hypergranulation can start going back. However, there are even hidden the overt, the classical, the normal signs and symptoms that we all know, the erythema, the warmth, etc., etc. So don't just think of these signs that we are used to, the open, the overt classical signs, but also things about the bridging, the granulation, etc. Spreading infection, now we are getting into trouble because now the microorganisms have started spreading around the wound bed. You might find some articles or textbooks that tells you that we diagnose a spreading infection when it is 2 centimeters or more of erythema. I don't totally agree there because it also depends on the size of the wound. If you have a tiny wound with erythema just spreading around it, there might show you that there is spreading infection. And we have to be careful because sometimes it can even be more dangerous, as you see at the bottom in that picture, where we have gas gangrene, which is caused by a specific type of microorganism. Spreading infection is easy to see, easy to understand. Look for that crepitation, but it also starts invoking other systematic factors like swelling of the lymph glands. And if we don't take care of the patient or the patient doesn't come to us early, we can go into systemic infection where now it's affecting the whole body, which can actually put the patient in septic shock and can actually kill the patient quite rapidly. Excuse me. So we have this vicious cycle here. We have the microorganisms multiplying, forming biofilm, and all of these start causing slough, which increases the, the microbial growth. And all of this also increases exudate. And this is very important to remember because unfortunately, sometimes we treat exudate as the most important thing. We make sure that we have a dressing that contains the exudate. That is good. However, remember that exudate is a symptom. So we need to treat the cause, and the cause of that exudate is the infection. If we don't treat the infection, we can keep on using these foams. They will keep on wicking the exudate. However, we are not treating the cause of the exudate, which is the infection. And then talking about biofilms, and biofilms are a huge topic nowadays. Everybody talks about biofilms. Many companies talk about biofilms, and we have to make sure that when we are talking about products that treat biofilm, we are sure, according to the evidence, that they are treating properly the biofilm. Because sometimes we might be tricked a bit, and we will discuss that a little bit later on. So what are these biofilms? So basically, it's a group of microorganisms that start aggregating together, attach themselves to the wound bed, and covers themselves with these APS. And remember, biofilms are not just a problem in wounds. Biofilms are everywhere. Actually, if you look at the history, the recent history of biofilm formation, it started with somebody in the 70s looking at water reservoirs. When it comes to medical, the first people who realized it are our dental colleagues. Maybe Maher can tell us more about it. Actually, if you wake up in the morning and slide the tongue over your teeth, you might feel a slide there, which is actually a biofilm. And biofilms are a huge problem even for, if you remember, for orthopedics, because an implant actually can be lost because of a biofilm. So what is this biofilm cycle? In the beginning, we have these free-floating microorganisms. And these are quite weak. We can flush them off quite easily. Then they start aggregating. They start become more attached. And they start creating an umbrella on top of them that will protect them from any attack outside. And it's called the extracellular polymeric substance, which is the EPS. And the problem with this EPS when they start proliferating and becoming bigger is that there will be an inflammatory response. What will happen? You will have the proteases, you will have the macrophages and the neutrophils trying to attack the biofilm, but obviously they are not managing to do it. What happens now is that they start actually attacking the wound bed, which will start creating that vicious cycle of the inflammatory process with the high level of MMPs coming in. So if we don't stop it before here, our wound will obviously become chronic and, will become very hard to heal, and we will have problems. So we need to treat it. Once these biofilm starts maturing, they start becoming bigger, they start becoming uh, more resilient, we will have also coming in the pro-inflammatory cytokines, the MMPs, increasing even more and more and more. And the problem over there is that now once the MMPs and the host-derived responses, you have the damage in the tissue that leads to more nutrition for biofilm, so it can actually become stronger and start multiplicating even more. And once these are mature, they actually start sprouting, and they start sprouting planktonic bacteria all around the wound bed. So we will have a total infection on the wound. We might actually have different biofilms in different areas of the wound bed. So we have to make sure that we are treating the whole wound. So what is this EPS? The EPS is made of natural polymers. However, what is very important to remember is that the EPSs establish the functional and structural integrity of the biofilm. It is kind of the umbrella on top of these microorganisms, which doesn't allow anything to go through. Why is it important? Why are we talking about biofilm? As we know, the topical and systematic antimicrobials will not be able to penetrate. The macrophages are unable to clear, so continuing to produce even more toxins and even going into that inflammatory process with the release of proteases, etc. So if we don't remove a biofilm, basically, we cannot heal the wound. And this is a slide that actually shows you that if we have a biofilm, even if there is not a huge inflammatory response, epithelialization will not be able to happen, and that epithelial gap will remain there. Now, what is the huge problem with these biofilms? When we're talking or between clinicians, or when we are looking at evidence about what is happening, we see issues where there are a lot of products which tells us, you know what, we actually killed the biofilm. But when you look at the evidence how it was done, the biofilm is disrupted, then the antimicrobial is put on top of it. And that is what is usually happening in the clinics. We clean the wound, we do the manual debridement, we remove the EPS, we apply an antimicrobial. But why is that a problem? Because within a couple of hours, those microcolonies start reattaching, and within 6 to 12 hours, they already have established an EPS around them. So either we change the dressing twice a day, or else we have to find a system that helps us remove the EPS in an effective manner and make sure that we can manage to remove the microorganisms and not allow them to form the microcolonies again. So we need something that clears away the EPS and gives a sustained release of antimicrobials within the wound bed. Now, another discussion. And many times you hear, oh, I've seen biofilm in that wound. Is that correct or is it not? And the answer here is always, to my questions, the answer is depends. Many times we see this translucent substance like a jelly form. However, this may be indicative of a thin biofilm, but it is not 100% sure. That opaque, loosely attached patches that sometimes we can remove. This can be a start of biofilm. Other obvious indicators where we have wounds with pictures like this, we definitely don't need to take any swabs or anything to recognize that these wounds are grossly infected by biofilm. And when you start removing it by a curette, you start seeing that jelly type, yucky problem that we are removing. Again, the issue is yes, we are removing the surfactant, but we are not removing the whole problem. And different biofilms with different types of bacteria might have even different colors and different odors, as you know. One thing that is a definite way how to do it is there are technologies like this is just one example, the wound mapping. There is also fluorescent, and there are other types of investigations we can take. But unfortunately, these are not widely available, and usually in our hospitals we don't find them. So how are we going to know that there is a biofilm in the wound? Sorry, is by realizing that our wound is not healing, by recognizing that chronic wounds usually do have biofilms and we need to remove it. One idea also how to try to understand if there's a biofilm or not. Sometimes if we take a wound swab, the wound swab culture will come back negative. Why? Because we are just taking the EPS. You can't go inside the bacteria and the microorganisms, so we don't find the microorganisms in our lab results. And obviously, if we are doing the correct care and the wound is not progressing, we always think that there might be a biofilm there. How do we effectively manage wound infection? And as usual, it's holistic management. It's not something that we treat just locally. The first one is making sure the patient is in the best optimal condition that we can get. Sometimes I get pictures from my colleagues. What do you think about this wound? What do you think about that wound? And although many times a picture says 100 words, when it comes to wounds, actually it doesn't. Because if we haven't taken a proper history, first of all, we don't know how much our patient will be at risk of infection, and we don't know why that infection is there. So once we know our patient, let's say a patient is a diabetic, are we controlling properly the diabetes? Are we minimizing the risk factors? And when we're talking about risk factors, remember even the way how we are treating the wound or who is treating the wound. The nutritional status, and this is why it's important in our patients with chronic wounds. These patients needs to be seen by a professional clinical nutritionist. We don't know. We are not expert in that field, definitely. I definitely am not. And just telling the patient, you know what, you need to take a high protein diet. We don't know. We need to call in the expert. The second one is the local wound care. How are we gonna remove the load which is on the wound? First of all, make sure that we try to prevent as much further contamination. And when we talk about contamination, we are talking about lack of aseptic technique, but also issues like I'm sure you have seen a sacral pressure injury that we cannot heal because there is contamination coming from feces. How can we control that? If we don't control that, we can use any type of dressing there. However, every time the wounds get soiled, we're going to have a problem. And we definitely cannot change the wound every time. There are ways how to do it, but just for example, two very obvious one is using fecal catheters or in extremes, even sometimes temporary colostomy. But think about other wounds as well. Antimicrobials and antibiotics when needed and as needed. We don't need to abuse the antimicrobials. However, if the patient is at risk, think about the benefit if we use it as prophylactic. Are we using antibiotics properly? And here the discussion also starts about where should antibiotics go? And if you look at the vial where we have an antibiotic, written on it, it says for intravenous use only. So when we are putting it on a wound bed, you are actually going against the manufacturer's guidelines. And there's a lot of discussions, and there are documents also from the World Union, but even up to the WHO, who tells us that we shouldn't be using local antibiotics locally. Another topic that also comes to mind when we're talking about antimicrobials and antibiotics is creams inside the wounds. Remember, when you are putting an ointment, a cream, or whatever inside the wound bed, you are putting in something that can actually create an inflammatory response itself because it's a foreign body. And whatever cream we are putting on today, we need to debride it when we change the dressing. I can't understand the rationale of using these creams where we have proper antimicrobial dressings that do the job effectively and can be removed quite easily. Then make sure that we are doing the proper care all over. And think about the health-related quality of life. Think about the psychosocial aspects of the patients. Where are we taking care of the patient? Who is taking care of the patient? Especially nowadays, and there's loads of webinars out there, and we actually had a webinar with Christine Van Ecker about the issue that this COVID pandemic has caused, because we have a lot of patients caring for their wounds at home, and there is an actual fear, and I've read an article about it a couple of days ago, that we are fearing that once the COVID starts calming down, we're gonna see a huge influx of patients coming in with infected wounds because they are not being taken care of properly. So patient education, carer education is very important. However, I also point out here, what about healthcare professional education? I always like to say that we don't know what we don't know, and it's actually more dangerous if we think we know what we don't know. So we might think that we are doing the proper care, where unfortunately, sometimes we are not. And obviously, as we go along, reevaluate, because a wound environment can change from one day to another. Make sure that we reassess. If the wound is not progressing properly, then we start all over again. What I suggest to you guys is, if you see the references down there, I'm referring a lot to a publication by the World Union of Wound Healing Society called The Principle of Best Practice for Wound Infection. But there's also a document by the IIWI, where they give very good guidelines about what we should be doing. And if you don't have a protocol in your hospital about wound infection, you can easily base a protocol or your guidelines according to these international statements. So that's it from my side. I hope that you found the session interesting, and now I will hand on to our dear friend Maher.
Thank you so much, Emilio. We will go into the question soon after a brief few slides on what could be an option in terms of local management of infection. As we always do, we have a brief talking about some of the treatment modalities from Orgo Medical that can really help in terms of the webinar topic. So today we'll talk about the local antimicrobial segment. So as we know, we have a lot of segments in Orgo Medical. One of them is the active defense, where you have wound care dressings to do local management of infection and in any infected wound, or if the wound is at high risk of infection. So it should be as a preventive or a treatment for infection. A lot of you maybe heard or already is familiar with Orgoclean AG and Orgotul AG, where they're both using the antimicrobial silver sulfate as a very well known antimicrobial added to the TLC healing matrix of Orgo Medical. So it is an effective antimicrobial contact layer to fight against any local infection with dry or let's say mild to moderate exudate wounds, where you can pack it, can be cut, can be used with other dressings as a primary dressing. The benefits you can get is that it has silver sulfate added to the TLC, where can be delivered to the wound bed and can really affect on multiple sites on the bacteria. such as the DNA, the respiratory enzymes, the cytoplasmic membrane, the cell wall. So it has a high antimicrobial efficacy, broad spectrum, and fast efficacy. Compared to also neutral dressings, compared to other antimicrobial modalities, we had a comparison in evidence-based publications to show the efficacy of these antimicrobial dressings. Of course, it is a traumatic because you know of the TLC healing matrix where you have a coating integrity for around 48 hours, not losing the integrity of it. Promote also the proliferation of fibroblasts, collagen, hyaluronic acids, and all of these benefits of the TLC and good tolerance of the TLC healing matrix. So again, you have the carbomethyl cellulose particles along with silver sulfate acting on your wound. So any wound of risk of infection or signs of local infection can be treated with any antimicrobial such as Urgotul AG. The proven antimicrobial efficacy can be shown in a very quick, very fast acting. Within 30 minutes, there is a huge efficacy on most of the well-known bacteria such as the MRSA, Pseudomonas, broad spectrum. So the log of the pathogens included in the antimicrobial effect is more than 40 strains, including bacteria, yeast, and any resistant bacteria. Also has a superior clinical efficacy compared to other neutral dressings and other antimicrobial dressings, all shown in publications. The Orgoclean AG actually covers more spectrum. As you have seen with Emilio, the problem is not just about the planktonic single bacteria. There is also slough, there is also biofilms. So what we really care about, or we want to show a visible efficacy of the modality of Orgoclean AG to prepare the wound locally for the next stage, to clean it from the bad environment such as the non-viable tissue, sloughy tissue, necrotic tissue, along with the antimicrobial anti-biofilm. So most wounds, and especially chronic wounds, actually has a vicious cycle of biofilm, and also single bacteria, and also the debris, the slough, the exudate. So we need to effectively fight against all of these three, break this vicious cycle, and prevent it from the formation again. So what is Orgoclean AG is about is an antimicrobial, antibiofilm complete cleaning action. Three modalities that really combine together to prepare the wound bed for the next stage. And as Emilio explained, the antibiofilm benefit is a huge benefit. As you've seen, bacteria will be protected from the antimicrobials by the EPS, and now local antimicrobials will not be effective as before, but you have an antibiofilm that is due to the complete cleaning action and antimicrobial all together from the same local modality. And it has a high efficacy of biofilm antimicrobial. This is a nice example, as you can just compare between an untreated biofilm on the left, where we just used an Orgotul, which is a neutral dressing, to show the bacterial proliferation, the biofilm existence. And when we use Orgoclean, Orgoclean has a desloughing, but there is no antimicrobial benefit to add up with the cleaning. So he removed the slough, clean it, but you need an antimicrobial in addition to the cleaning mechanism to have an antibiofilm dead zone. So you can see on the right side the gray zones where you have a biofilm destruction caused by a complete cleaning action, along with an antimicrobial silver sulfate acting on with the cleaning or desloughing mechanism. So that's the difference between having just antimicrobial alone, or just debridement or desloughing or any kind of cleaning mechanism alone. Both together doesn't give us the full benefit of the combination together. We've been through this many times. Ergoclean AG actually goes into a very high level of evidence, including an RCTs to show the efficacy of the antimicrobial inside it, acting on more than 140 strains of bacteria, showing it on chronic wounds and other acute wounds. Also, we have an RCT comparing the desloughing or the cleaning action of Ergoclean versus one of the highest or well-known previously wound management dressing, Aquacel, in chronic wounds, and we had good and significant results in terms of cleaning. And in combination to these two RCTs, we have clinical studies in many chronic wounds such as diabetic foot ulcers, venous ulcers, and pressure injuries to show the anti-biofilm activity, the antimicrobial efficacy on these wounds. As just to build up on what was explained by Emilio, this is one of the cases that really shows the local signs of infection, slough, and most probably the biofilm. So again, we need a local treatment or a local management to do that. And as soon as we started the treatment with Ergoclean AG, you can see above the Ergoclean AG discoloration into greenish with a high viscosity exudate, as this is an indication actually to let's say the amount of infection, the amount of slough, the amount of biofilm we have there. As actually we couldn't diagnose it, but it's visible. We cannot really do any test, but local signs were more than enough. So the principle of wound care is just to prepare this wound with local management of antimicrobial, anti-biofilm cleaning action, which was a huge wound and took us a bit of time to clean it and prepare it and to reach a level where it is clean and ready to the next modalities of, in this case, we had negative pressure therapy along with Ergostar to promote the proliferation of granulation and proliferation of collagen and to close the wound till the end. Examples at the end to show the cleaning mechanism, the antimicrobial against the greenish color here indicates Pseudomonas, as even with the test Pseudomonas was identified. As you can see here also in the scalp, we clean the wound. Here we have a hypergranulation indication infection, indicate the infection, and we clean it with Ergoclean AG to prepare it for next step. This yellowish is actually the bone, which is not slough. So this is a clean wound bed. Here as well as these wounds, we reach from a stage, we have a very exudative, very smelly, greenish, infected wound to a healthy tissue ready to receive the next step, either a graft or whatever treatment modality was decided. So this is it. So Ergoclean AG is actually a wound care management dressing to give you the benefit of antimicrobial, anti-biofilm, and the complete cleaning action. Are you using it on all exudating wounds infected or with signs of a local infection? Of course, the duration of treatment is according to the international guidelines, not to exceed a month. Then you can stop for a period of time around a week or 2 weeks. Then again, use it if necessary. And the dressing renewal could be 1 to 2 days, but it's always depending on the wounded, exudate, and all of this. Short video, just can you hear the sound? Maybe I didn't share. Stop sharing. Share again. Sorry for that. Yeah. It's a nice video showing the component of the dressing as well as the mechanism of cleaning, and also this was shown in the clinical cases before. So in Urgo Medical, we actually care about healthcare professionals and our patients. So we have a campaign of fighting local infection where healthcare professionals should be informed where you have any signs mentioned previously by our clinical director, Mr. Emilio. That's it for me as well. Thank you so much. Shukran for being here and listening to our webinar. I think we have quite a number of questions. We can answer them now. Emilio.
Yeah, we have a first question, which is quite interesting, about a discussion lately that was happening. There were some blogs talking about the coronavirus. Is it actually a virus or a bacteria? That was definitely fake news. It is not a bacteria, it is a virus. And unfortunately, we have to treat it as a virus. A very question by Turki Salam, where he's talking about, are there any parameters that the limb should amputate it and no benefit from debridement? We always talk about life before limb. If there is a cause of concern that the infection might go on to a systemic infection, then we should definitely, especially if we're talking about issues like gas gangrenes and however, there are times where we saw wounds which we thought we wouldn't be able to manage. Always give it the chance. If it is not putting the patient's life at risk, we should always give the wound a chance to see if we can actually manage to heal it. If we find that it is going to affect badly the patient, then definitely we have to make sure that we are treating life before limb. There's a question from Fatma Aldawi talking about what type of microbes can be killed by the Urgotul AG silver dressing. We have a list of microorganisms, and there are in vitro studies that show that it kills 99.99% of the microorganisms. It's a broad spectrum because it's a silver dressing, and it kills the same bacteria that all the other silver dressings kill. If you do need further information about this, we will be more than happy to send you a list. But you can keep your mind at rest that when you're using silver is a broad spectrum antimicrobial that would give you the benefit of its broad spectrum in killing all the microorganisms within the wound bed. We have both in vitro and in vivo studies. What is very interesting with the Urgotul AG is one of the studies that was mentioned by Maher previously is that it doesn't just show the effectiveness of it being an antimicrobial, but preparing also the wound for healing because of the TLC matrix, which is a healing matrix. So it is safe to be used on the wound, preparing that wound for healing as well. Unfortunately, some antimicrobials would be detrimental, especially to the fibroblast, where you have Urgotul AG because of the TLG, it actually proliferates the fibroblast. Yeah. Susan talked about what are the contraindications. The contraindications, if you have silver, is if there is hypersensitivity to silver. We've been using Urgotul AG now for the past, I think, 16 years or so. We didn't have problems with it. So, and the Urgoclean AG is the same type of silver, which is the silver sulfate. The amount of silver in the product is around 18 parts to 19 parts per million. So it is an effective way of killing the microorganisms as shown by the in vitro studies, but not detrimental for our patient. What to do according to Naiv's question, what to do with a sacrum ulcer where bone exposed and the wound is very big and infected? If you're gonna use negative pressure or antimicrobials, protect the wound bed. So the suggestion would be try to clean the wound bed as much as possible by means of debriding, sloughing, using something like Urgoclean AG. If you're using an antimicrobial, try to protect the bone by means of a neutral dressing. So if you're using, let's say, Urgoclean AG, put a little bit of Urgotul on it so the silver is not in direct contact with the wound bed, with the bone. Even if you're using negative pressure, be careful that you have to use an interface on a bone, because if the negative pressure is indirect with the bone, you can actually desiccate the bone. Obviously, offload the patient, holistic care of the patient with nutrition, turning, etc., etc. And if it is quite big and infected, and probably you have spreading infection, you will definitely need systemic antibiotics as well. So, question from Rima, what are the possibilities for using vacuum dressing, especially with heavy exudate if we are using Urgo dressing products? Negative pressure can't be used with the Urgoclean and the Urgoclean AG. However, if you're using the Urgotul range, which is the neutral Urgotul or the Urgotul AG, you can place the negative pressure on top of it without any problem at all. Actually, we have a publication from France which shows the benefit of using an interface layer on the foam. When I was working in the hospitals, the last one was Mafraq Hospital here in Abu Dhabi, I always used an interface layer underneath the foam. Why? Because negative pressure is really a good therapy, but the problem is that you have the ingranulation inside the foam dressing of the negative pressure. When you remove it, it causes bleeding and it causes pain for the patient. When you use an interface layer, once you pull the drape, actually the foam lifts off the wound without any trauma to the patient or trauma to the wound bed itself. One very important thing, if you're using any interface layer, is that overlap it a bit on the skin surrounding the wound. Because if you don't, when the foam collapses, it will pull the foam down and you'll find the interface layer pulled at the bottom. So always overlapping on the peri-wound skin and use the drape to anchor it. If you're using the TLC range, either the Urgotul or the Urgotul AG, it's not a problem. It will not harm the peri-wound skin at all. Very interesting question by our sorry for the pronunciation, Estrada. How long can silver be used? If you look at articles again from the West, they talk about the 2-week challenge. If you're using silver in a wound for 2 weeks and it's not working, then there is something wrong. And that's usually the rule of thumb. If you're using silver for 2 weeks and the wound is still infected, there is something wrong, either with the patient himself or with the wound bed itself. Normally, if you're using products, let's say like Urgoclin AG, but any other antimicrobial, within 2 weeks, if you're doing a holistic management of the wound, you should be seeing progress. And as we've seen from the cases that our dear friend Maher showed us, we do usually see a lot of progress within those 2 weeks. One good thing that we were talking about, remember that chronic wounds normally have a biofilm. So usually before starting any treatment to start healing the wound, we apply something like Urgoclin AG to remove the biofilm to make sure we don't have a biofilm there. Rima asked us how frequent to change the dressings. All our range would be good for 7 days. However, if a wound is infected, obviously you don't wait for 7 days. What we suggest is that we use the dressing for 2 to 3 days and change it every 2 to 3 days, especially in the beginning of the wound where you have high exudates. Make sure that you are changing it more frequently and using an absorbent layer on top of it to wake up the exudate, right? Revelita asked, is it safe to use silver dressings on neonates? When it comes to neonates, I would be very wary to use local silver. Remember, we are talking about babies which are usually as big as our palm. I would be a bit wary to use it. In pediatric patients, it is usually safe to use it for a short period of time, but I wouldn't suggest to use it in neonates. Can Urgotul SSD be applied on skin bears or still needs flamazine? Well, if we're talking about the Urgotul SSD, Urgotul SSD is the same functionality as the SSD cream. Both have got SSD. So when you're using the Urgotul range, you don't need to actually use the Urgotul SSD. You can use the Urgotul AG, which actually is more broad spectrum and can be left for a longer time in the wound. Using creams on wounds is a huge problem, as I said before. We know that creams actually produce what we call pseudo-eschar. That is why you need to change the dressing at least every 24 hours. Causes pain to the patient. You need sometimes to take the patient to theater. So rather than using a cream which is messy, can macerate and have problems, use a dressing that can be left longer in in place, and then lifts up. And remember that both the Urgotul AG and the Urgotul SSD have the TLC layer, and the TLC layer is there to assist in creating that wound healing environment. Hyperpigmentation with the use of Urgotul SSD, what maximum of duration can you use for 6 months to 10 years? We have not heard of hypergranulation because of the Urgotul range. Usually the hypergranulation is there because of systemic factors rather than the dressing, which is local. As we said, for pediatric patients, you have to be quite careful. The younger the age, the less you use. don't use it for a very long time. I wouldn't suggest to use it more than a week. How long should I use one dressing? If there is a limit to using one dressing. Well, depends if you're talking about antimicrobials. As I said, if within a couple of weeks the wound is not healing, it's probably not the problem of the dressing. It could be a systemic problem or an environmental problem. If you're using a dressing which is helping the patient to heal, you can continue with the dressing till the end. Like we have dressings like Urgostart and Urgostart Plus, which we suggest to keep on using till the end. Another question here about utilization of NERDs and Stoney's criteria. And yes, it is. These are. It's a very nice article. You can Google it. You will find it. It's a free article from Wounds Canada. And NERDs and Stonies can actually help you identify very, very easily, especially when it's talking also, the same article talks about the slide that I showed about the covert and overt signs. It's a very nice article to read. If you send us an email, I can actually send you the link or send you the article. It's a very, very good read. Thank you very much, everybody. I think that's the end of the question session. Thank you very much for the compliments that you send us in the chat and the Q&A.